afternoon and welcome to this Observatory webinar all about health system effects of economy-wide inflation and how resilient are European health systems. So for years, researchers have said that prices drive health expenditure growth to unsustainable levels. But the recent cost of living crisis brought renewed attention to this issue as rapid price growth in the wider economy has put additional upward pressure on health sector prices. Inflation impacts health budgets and the wages of healthcare workers, but inflation has also had an impact on capital investment costs. The effects of high inflation vary substantially across purchasers, providers and patients, depending on factors including health system characteristics, regulatory mechanisms, market power, provider cost structures, and indeed payment mechanisms. But right across Europe, countrywide inflation has been testing the resilience of health systems that are still recovering from the COVID-19 pandemic. So today we're going to learn all about the determinants of health prices, how health prices vary across countries and using new measurement techniques, and the extent to which health systems across Europe were resilient to economy-wide price pressures during the cost of living crisis. Now, to do this, as ever, we have an awesome panel of speakers today to fully explore the topic. First up, we have Irini Papanikolaou, who is Director of the Centre for Health Systems Sustainability and a Professor of Health Services Policy and Practice at Brown School of Public Health over in the USA. It's very early in the morning for her, but she's kindly joined us, and she will provide an overview of the whole subject area. Next up, we have Luca Roinsoni, who is an economist at the Health Division in the Organization for Economic Cooperation and Development, the OECD, in Paris, to talk about measuring prices. And finally, we have our own John Cylus. He's in the European Observatory on Health Systems and Policies, where he is head of the Observatory's London hubs, based both at the London School of Economics and at the London School of Hygiene and Tropical Medicine. He's also with the WHO Barcelona office for health systems financing in Spain. And John will be shining a spotlight on the cost of living crisis. Now, as ever, we will then have plenty of time for your comments and questions from the chat box. Please do not be shy. Ask your questions and we welcome your comments, insights and country experiences too. The chat box today will be moderated by my wonderful colleague Astrid Eriksson, who will now introduce a poll question for you all, so we can have a little insight into your thoughts out there in the audience. Astrid, over to you.
Welcome to all the audience and the panelists. It's great to have you here today. And yes, we have indeed prepared a question for you. You should be able to see it on your screen right now. And it is, in your opinion, what was the main consequence of the recent cost of living crisis in your health system? And it's a multiple choice question, so you can say whether there was no impact, higher unmet need and catastrophic spending, health workforce strike action, increase in volume of care provided privately, increased prices meant increased health spending, increased prices meant reduced volume of care provided, all of the above and none of the above. So yeah, please do fill out the poll, and I'm very excited to see the results later. And back to you, Erika. Thank you.
Thank you very much, Astrid. So we will give you time to answer the poll, and Astrid will come back with the results after Luca's presentation. So without further ado, I would like to hand the floor to Irini Papanikolaou. Irini, over to you. Thank you.
Good morning, good afternoon. So I just want to get us started by kicking off a little bit about why talking about price growth on health systems, the role of inflation, is important for thinking about the resilience of health systems. So if we look at health expenditures across OECD countries, we can see that they're varied. The US leads, as we know, at about 16% of GDP in 2002, and the OECD average is at about close to 9% of GDP. But this has been growing steadily over time, with a lot of fluctuations recently during the pandemic and during the cost of living and inflationary crisis following. You can see that prior to that, health spending was growing at faster levels than GDP, which it often continues to. And this poses an issue for how much it will grow and how fast it will grow. This poses an issue because it can crowd out other areas of public spending, and there's concerns about just how sustainable being able to pay so much for healthcare is in the future. So really, curbing the cost curve is essential to have resilient systems because public budgets are already constrained, and there's only so much that countries can put towards healthcare. Becoming more efficient means that we can spend more on services that are important for the population without compromising on things like quality. And so really understanding where we can find these efficiency gains to curb the cost curve is essential for ensuring that we can be resilient and sustainable in the future. So if we think of what constitutes health expenditures, we can think of this simply as the product between the volumes of services that we consume and the price of those services. And therefore, if we see increasing health expenditures, we can break this down into what is driving upward pressure on volumes and what is driving upward pressure on prices, and think of those different mechanisms separately to try to think of where health systems can intervene to curb health expenditures. So here I've listed in the two boxes several upward pressures that health systems are currently facing on prices as well as on volumes. So if we think for a second about the upward pressure on prices, one big area that has received a lot of attention in recent years is innovation. And these new and really exciting innovations that are emerging, such as gene therapies and other therapies in areas such as cancer, which are really innovative and offer important gains in healthcare, but come at a very hefty price tag. So how do systems adopt this innovation without breaking the budget? Another concern, which Erica mentioned already, is the cost of living crisis and inflationary pressures. In the past years, we saw much higher inflation than we had seen in prior years. And health systems had to think, how does this affect the cost of inputs in the system, the prices that I pay for services, drugs, labor, and how can the health system protect itself from these different inflationary pressures? Also, something that's been discussed in the health economics literature for several decades is that healthcare provision, given that it's a service, is labor heavy, and salaries can rise fast because of cost pressures in the general economy, and this can make, again, the health expenditures subject to growth through the pressures that are put on wages. If we think on the other end, what are the upward pressures that health systems are facing on volumes that they might want to control or need to think about? One that is discussed very much is the aging population. As the population across all countries ages, we have a population that is going to need more healthcare, and this is going to put more pressure on volumes. Relatedly, we see increasing multimorbidity in the population. Again, this means that we have a population that's living with more chronic illness that will need to consume more services, and this too can put an upward pressure on volumes. And innovation. As I said before, we have this new innovation, new drugs, new therapies, new tests emerging into the marketplace, and therefore there may be more demand and more volume to consume these new services. So we see here that really what I want to take away is that there's two components that can drive up health expenditures, price and volume. And in our current climate, we have upward pressure on both of these things that are pushing health expenditures up. But there are many efforts that health systems have, many policy tools that they can use to control both prices and volumes. And different systems use these tools differently. So what I want to do is lay out what some of these tools are independently for prices and volumes. And then later we can think about how systems use them, which tools are more effective, and how we can answer this question of which tools are more effective and learn from one country and another. So if we think of controlling prices and price growth, how can systems do this? My first 4 points have to do specifically with how we set prices, how we regulate prices. So first, we can think of just how prices are set in the system for different types of goods and services. This could be salaries, this could be the price that health systems or payers pay for inpatient care, primary care. And so systems set prices differently. This could be unilateral price setting. This could be together with physicians or providers, and this differs importantly by care setting. But health systems do vary in the way that they set prices, and we believe that there's something to learn about which types of price setting might be more resilient towards inflationary pressures or other pressures. There's also new payment models that is related to this, which have been introduced over time in many health systems to try to change the incentives of payment and also promote more efficiency. So for example, new value-based payment models try to shift paying for volumes or from fee-for-service methods to paying more with a focus on quality or efficiency by setting budgets for certain populations or attaching incentives linked to particular indicators of quality or efficiency targets. We can also see different price regulation in countries. And this could be, for example, where systems intervene if they see that expenditures are exceeding a certain target in a year and coming in and rethinking the price they're going to pay or volume controls, which I'll talk about in the next slide. But that has to do maybe with more monitoring of expenditure growth and coming in to regulate prices when needed. Price transparency is also a tool that many systems have used, and this particularly can address price variation within a system and ensuring that there's more consistency across prices and also then controlling prices. So here, if you think, for example, what is the cost of a colonoscopy and reporting on that across different providers so that those prices are transparent and consumers or other payers or purchasers know what the price is, and hoping that this transparency leads to more control and more uniform price in the system. Another tool that's separate from this direct regulation of prices is competition. So the idea here is that several providers competing will bring down the price as they do in other markets, and several health systems have experimented with competition in different forms to control prices as well. And related, I guess, again, to price setting, specifically for drugs and devices, we have health technology assessment. So here the idea is, again, that we review the evidence around new therapies, new innovation, and the benefit that they offer over existing therapies, and use this information to set prices and discuss appropriate prices with manufacturers. So on the price end, we see that there's many different tools, and these are used very differently across systems. So it's important to learn what's more effective, what works better in different types of systems. On the other end, we can think of volume control as another way to control health expenditures. And so here again, health systems have several policy tools at their disposal that they can use. And I should add, for both of these lists, this is non-exhaustive. There are other policy tools. This is just an illustration of some of the tools. So if we think of volumes, again, we could see there's volume setting, so contracting for volumes, even volume caps. We could see this, for example, in contracting for inpatient care, setting certain volumes at the beginning of the financial year that the payer will contract from different providers. Different systems use this to different extent. And again, as I said before, you can revisit this throughout the year if you see, or some systems can revisit this throughout the year if they see that expenditures are growing. Within primary care, we see that trying to shift to a more primary care centric model, where particularly for an aging population and multi-morbidity, you have more continuous coordinated care in the primary care setting that avoids costlier inpatient care. Gatekeeping is another tool that systems have used to ensure that patients go to primary care first and see the primary care provider before going on to more expensive inpatient care. So thinking about how we can coordinate care and integrate care across different care settings to make use of all of the different components of the system and spread the cost. So these are just, again, some of the different things that systems do. So just some considerations before I pass on. When we're looking at measurement and thinking about these tools, prices don't mean the same thing across health systems. Prices are set in different ways, and this influences what we observe. So this poses a significant challenge for measurement and how we evaluate these reforms, and my colleagues presenting next will talk about this. And another thing that I mentioned a little bit, but did not discuss fully, is that central to this agenda is thinking about how we promote high quality in the system when we're trying to control either prices or volumes to ensure that we're not compromising quality. And several of these mechanisms try to take that into account, but I'm happy to discuss this more later in the discussion. So thank you very much. I'll pass over to Erica.
Thank you so much, Irini. Thank you. And I forgot to mention it earlier, but my colleague Astrid will put the link in the chat box. This work is based on a policy brief, which is available free to download from the Observatory website. So please do check it out in more detail there. So there's our overview. Now let's go into a little bit more detail into measuring prices and some of the new techniques that have been developed. Luca, over to you. Thank you.
Thank you, Erica. Irini just mentioned the importance of two components, price and volume. So in the next 10 minutes, I will offer some thoughts about how going along with disentangling price from volume, also highlighting some of the measurement challenges we face. Next slide, please. At the OECD, we gather data on health spending at current prices from countries on a yearly basis. Then what we do, we look at growth over time using time series of those data we collect from countries. And I guess one of the main task of the analysis is really to understand how to separate the price component from the volume component. Basically, how we can deflate, that's the national accounts jargon, which is used, the health spending time series we gather from countries. To do so, it's important to identify which price index we use to deflate expenditure in current prices that we gather from countries. Next slide, please. I think that for an international comparison, we could use different deflators, so different price indices, to come up with a measure of volume. So depending on the question we're interested in and the indicator we use to compare across countries, we may want to use different deflators. We could use deflator at the economy-wide level, the so-called GDP deflator, when we want to reflect changes in the price of all goods and services that comprise the gross domestic product. We could use deflators linked to the actual individual consumption, which is consumption of goods and services by household, independently by who paid, the subject who paid for those services. But we could also use deflators, price deflator, which reflect consumption expenditure, final consumption expenditure by government, and final consumption expenditure by households. For the government component, we got two main price indices. One reflects the collective components, collective consumption by government, and the other one, the individual consumption. For household, we got also specific price indices, which we could estimate for health. So household final consumption expenditure for health. So for example, if you are interested into comparing across country health spending per capita over time, I guess we may think about coming up with a price deflator, which capture the final consumption expenditure of household on health and the individual consumption expenditure of government. To do so, we may use national accounts time series, which are available at the OECD, but also are available at other international multilateral organizations. And what we gather from countries is both time series in current prices and in constant prices. So when we divide time series in current prices by time series in constant prices, we can come up with what we qualify as an implicit price deflator. What is the likely impact of using different implicit price deflator on our price and volume measures? Next slide, please. We look at this by comparing price and volume measures across 5 high-income countries, OECD high-income countries, and try to capture the impact of using a health-specific deflator to disentangle the price component from the volume component. In this table, we compare what if we use a GDP price deflator, implicit price deflator, what if we use an actual individual consumption implicit price deflator, and what if we use a health consumption price deflator? What is the likely impact on volume? And so you see, we look at the annual average growth rate in per capita health spending between 2000 and 2020. And what this table tells us is that basically, if we use a health-specific deflator, implicit price deflator, you observe a decrease in the growth in volume. So for example, for Australia, we see that the annual average growth in health spending in volume terms between 2000 and 2020 is 3% as compared to 3.4% if we use an actual individual consumption deflator, which relates to all goods and services consumed by household, not only health. And also we wanted to see whether those health-specific price deflator allows us to get an estimation which is closer to the national estimates of volume based on national price indices, which is the last column to the right. And this is the case too. So why so? Next slide, thank you. Because what we observe is that the cumulative relative growth of health prices to general prices is quite consistent, in particular for countries like Canada and the US. So between 2000 and 2020 in the US, for example, this cumulative relative growth, we observe a 14% increase or excess price inflation, health price inflation, as it's sometimes qualified in the scientific journals, 12% from Canada. So this tells us that the price component would be more important if we use a health-specific price deflator to disentangle the two components, which, as we show in the previous slide, has an impact on our way to measure growth in volume per capita over time. The last point I would like to touch upon, which is next slide, refers to also the importance of looking across countries. So the first part of this presentation was about temporal price and volume breakdown. I think it's also important to reflect about how to compare across countries. So an inter-country index, which could help us identify how price levels have an impact on the measure of volume. I just provided an example of the total expenditure for a year of care for a hip cohort. This was a study coordinated by IRINI, the iconic network, which look at high cost, high need patients. In a few words, what we see is that if we use a condition-specific price deflator, in this case, constructed using prices for this cohort, hip cohort, collected by the different providers, the difference in volume in between the US, the first bars to the left, and the other countries, Canada, Germany, France, Sweden, and Spain, we compare the US to, narrows down quite significantly, which tell us that eventually, in terms of volume of care, the difference in between countries is not as large as we could estimate using an actual individual consumption deflator. And so I think, again, this point to the importance of selecting the price deflator, which could be the most appropriate to answer the question we have in mind. And with this one, I think I thank you very much, and I pass over the floor to Erica again.
Luca, thank you so much. That was really fascinating. And it's going to be really interesting to see how that fits with the findings from our poll. So, Astrid, if I could hand over to you, what's happening out there in the audience?
So I'm about to get there. I have the results now. So around or 43% said that one of the main consequences of the recent cost of living crisis in their health system was higher unmet need and catastrophic spending. And then 46 said increased prices meant increased health spending. And 35% said increased prices meant reduced volume of care provided. And then we had 28% saying health workforce strike action, and 13% said all of the above, so all of the options provided in the question and not just the one that I've listed now. So that's my main takeaway from the poll.
Yeah, I mean, that's quite dramatic, isn't it? Where all of the above is sort of 1 in 5 of respondents almost. So thank you very much for that. Time to hand over to John Cylus, who's now going to talk about the broader cost of living crisis and how this all fits together. So thank you, John, over to you.
Thank you, Erica. I'm going to talk about a policy brief that we've just released today, which gets at this question actually that appears in the poll of how health systems are affected by economy-wide inflation. So this is work that I did with my wonderful colleagues, Patrick Yersin, Rono Hassan, and Marian Den Besten. So I wanted to motivate first by looking at some data on inflation. So this is data from Eurostat, which show consumer prices over the past 15 years or so for countries across the EU. And you can see that around Q2 of 2021, there's this very, very large spike, the beginning of a spike in consumer prices across the European Union countries. And this peaked in October of 2022 at about 11.5% price inflation on an annualized basis across EU countries. And so this increase in prices, we've heard about the role of price versus volume and how to measure prices, but I think this raises really interesting questions about how do prices in the wider economy affect the health system. And so to try and answer this, we did this policy brief, and we first created a framework to sort of guide our thinking, which I'll show here, and I'll try and walk through very quickly. So if we imagine that prices in the overall economy at the very top are increasing a lot, this could have a number of effects theoretically, on public sector revenues. So if the prices of goods are increasing and you're taxing these goods, you theoretically should be getting more money, more taxes from those funds, from that revenue base rather. Likewise, the value of the real value of public debt will decrease as inflation increases, assuming that interest rates stay constant. So the cost, the money that has to be repaid by government, the value of that money will shrink because money is worth less. But then if we get to thinking about the actors of the health system, so in the purchaser in the health system, we created in this framework, you can think about this as being a continuum from left to right. So on the left, you can imagine a purchaser with very little exposure to market prices. So a monopsony purchaser, a single purchaser. On the right, a purchaser that is fully exposed to market prices, so a much more competitive system. And of course, a purchaser that is a single payer, so a monopsonist, where they are dictating prices, will likely have much less, at least in the short term, inflation will have much less of an effect on their ability to set prices. So they are relatively insulated from economy-wide inflation, whereas purchaser, which is simply reimbursing the costs that providers are charging, will of course the input costs will feed through to the prices that they pay. If we think about providers, so providers, I would say between purchasers and providers, our thinking at least was that providers would be much more vulnerable to economy-wide price growth than purchasers, because they face much more market prices. Usually they have to buy goods and goods, they have to pay worker salaries. But there are some providers that have a lot of market power where they can dictate the prices that they charge purchasers, or they can dictate the prices, they can buy things in bulk from suppliers. Maybe there's centralized procurement. So there's a lot of potential variability in how much providers are exposed to prices. And lastly, patients. So obviously, if patients are paying for everything out of pocket, then if providers increase their prices, patients are going to feel the brunt of this. Whereas if patients are very well insulated from prices because there are no co-payments and they're using publicly financed services, or if those co-payments are fixed rather than some percentage of the price of a good or service, this will all dictate the extent to which a patient is affected by prices. And so we used this framework to create a survey, and we surveyed 21 countries, and we held 2 focus groups. And I'm briefly going to show some of the results of what we found. So the main finding, I would say, is that most countries don't automatically update their budgets or the prices that they pay to account for inflation on an annual basis. So among the countries that we surveyed, Bulgaria, Cyprus, Czechia, Estonia, France, Greece, Ireland, Lithuania, Romania, Spain, and Sweden all did not have automatic updates that would adjust their prices or their budgets. Actually, one of the few countries that did have an automatic update is Luxembourg, which updates its budgets and in that sense also prices once inflation goes above 2.5%. That being said, we talked in Luca's presentation about measuring healthcare specific prices versus wider consumer, the prices faced by consumers. But the countries that do update their prices or their budgets, they usually use the consumer price index. So they don't use health specific prices to update the prices that they pay for services. As expected, providers are oftentimes the most exposed to inflation, because whereas the purchasers in European countries oftentimes are able to dictate prices, at least in the short term, providers have much less say over the prices that they receive. And so one of the things that we found is that providers compensate for their lack of an ability to influence prices by influencing volume. So where there's more dual practice, they try to take on more private patients. Where they can charge for services that are not covered, they will do that as well. And obviously this has an impact on households who struggle to pay for healthcare. We also found that the increase in prices led to higher building costs, higher materials costs, plus the increase in interest rates as a result of attempts to address the inflationary crisis, led to delays in capital investments. And so there are some exceptions, especially through the European Recovery and Resilience Fund, where countries were able to maintain some of their planned capital investments. But in many cases, new projects were delayed or canceled. And even with the European Recovery and Resilience Fund, since the outlays were dictated in nominal terms, it meant that as inflation took hold, the purchasing power of that funding declined as well. So there was clear effects on the ability for health systems to engage in capital investments. And lastly, there were some countries that took steps to reduce out-of-pocket spending on healthcare by freezing co-payments or by creating more exemptions or lifting co-payments, or freezing even voluntary health insurance premiums, like as the case in Slovenia. However, we found more often the case was that it was non-health system policies that protected household finances. So things like energy subsidies and other sorts of government funding to households that was not directly targeted at reducing out-of-pocket spending. This seemed to be a more common way to respond to the cost of living crisis. Just to illustrate the impact of cost of living crisis on household finances, we did this simulation, which looks at how catastrophic and impoverishing health spending in EU countries would likely be affected if households continued to use spend out of pocket, they continue to use health services, but their cost of basic needs increased by 10%. And so that 10% figure is roughly in line with the average, the peak of inflation in EU countries of 11.5%. And what we found is that even if households didn't spend more out of pocket, so even if they were well protected by the health system, just the fact that their cost of meeting basic needs increases would increase the incidence of catastrophic and impoverishing spending. So catastrophic spending would increase on average by nearly 2 percentage points, with the highest increase being in Bulgaria, Hungary, and Romania. And the impoverishing spending would increase by about 1.3 percentage points. So my final slide, so what are the implications? What are the takeaways from this? I think the main takeaway is that inflation matters for health systems. So, which seems like a very obvious takeaway, but of course we found that health systems don't usually automatically account for inflation in their budget setting or price setting. And I think it's as I wrote here, it's very tempting for a single purchaser or a monopsony purchaser to set prices to sort of insulate themselves from economy-wide price growth. However, what we saw, of course, in European countries is that you can only do this up until a point, and after which health workers go on strike. There's much more of, like I was talking about, these shifts where providers find some way to maintain their income to the best of their ability by shifting costs towards households. And so our broad recommendations, if you could call it that, for how a health system should design strategies to respond to economy-wide price growth is having some reasonable compensation for providers. Obviously not an automatic one-for-one, as prices increase in the broader economy, the health prices should increase as well. This would be unsustainable. This would drive even more price growth, expenditure growth, as Irini showed in her earlier slides. Ring fencing investments, so capital and workforce, making sure that this money is available no matter what happens in the broader economy. By prioritizing financial protection for vulnerable populations. So again, just the increase in out-of-pocket the cost of basic needs alone leads to an increase in catastrophic and impoverishing spending. So how countries need to prioritize removing co-payments or providing more protections for those who can't afford it. And lastly, containing growth in parallel private care sectors. So again, where providers feel squeezed, they will find alternative ways to push patients into the private sector. And so making sure that this doesn't grow uncontrollably and challenge the solidarity and universality of health systems is important. And with that, I pass it back to you, Erica.
John, thank you so much. That was a very densely packed insight overview there of the policy brief, but also of the really quite big issues that the health systems in Europe have been facing this year. So with that, I want to now hand it over to the audience. We want your questions, and I'm going to hand over to my colleague Astrid, who's been monitoring the chat box and is going to feed back your questions to us. Over to you, Astrid.
Thank you, Erica. Yeah, I have prepared or picked up 2 questions. Maybe we should start with a question to John, as he just left the stage. So I invite you back to the stage. And that is, maybe you can talk more to when or if we have certain health system indicators going up while we have inflation and we see increased prices. There was a question about waiting times. What should we make of that? Should we see that as a sign that a health system is not financially resilient, or what is the takeaway from that? And then a question for Luca, maybe you can come in here and maybe talk a little bit about quality. How does quality of care fit into this whole discussion about prices and volumes, and how that sort of fits together? So I want to leave it there for now, and then maybe this inspires the audience to put in their questions for a second round of discussion.
Thanks.
Okay, thank you very much. So John, over to you.
Yeah, no, so I think, I mean, in a way, Astrid, you almost answered the question. I think you're right that looking at indicators like waiting times, looking at unmet need, although obviously that would be available on much more of a lag, would give you a sense of whether providers are, whether there are barriers for patients to access care, which could be driven by inflation. I think that the most important thing probably is ensuring that there aren't these incentives in the system, so that there is that providers don't have the incentive to try and push people to the private sector. So ensuring that their incomes are maintained. I mean, if you look at the UK, for example, there were so many doctor strikes, nurses strike, because of the prolonged period of not adjusting wages to account for inflation. So I think it's the kind of thing that needs to be dealt with before it becomes cumulatively too much of a gap between the way that prices have grown and wages grow. Otherwise, you have this need to really play catch up and have a really large one-time increase in wages. So yeah, I think that really monitoring private utilization of healthcare is a good way to try and be aware of whether this is already happening, but it's very difficult to do that in real time.
Thank you very much. Luca, did you want to talk about quality?
Yeah, thank you, Erica. I guess there is no consensus about how to embed quality measures into this two components, price and volume. My sense is that quality could be very much linked to the volume component by, for example, differentiating products, so goods and services, which we use as a basis to come up with an estimate of health spending over time. So if we offer, as Irene mentioned, a new technology, which is most likely a higher price, but better quality, then the product differentiation will account for a change in quality. I think the two questions are linked, actually, because waiting time could be also a way through which we could measure quality. It's a quality from the user point of view, but still, this gives us an idea of eventually how to capture changes in waiting time into a volume component, because I think it could be one of the indicators we use. It actually, they are used for example, for measuring changes in productivity. So in a nutshell, there's no consensus, could be very much linked to the volume component. We should clearly identify which indicators to use to adjust volume, and differentiation in prices over time could be a possible way forward.
Luca, thank you very much. Irene, is there anything you would like to add to this around rationing care or about price controls?
Yeah, I think just coming back to quality, I mean, I think this is a really interesting and very important consideration that we need to think about as we're thinking of policy tools that governments have as we evaluate their effectiveness in controlling prices or volumes. And I think there's two things to consider. One is, as Luca mentioned, the measurement component. You know, if we're measuring volumes to back out prices, ensuring that and countries have done this. We haven't done it yet in comparisons, but some countries like the US, like the UK, have looked at measuring productivity and thinking of how they measure volumes, not in terms of activities, which wouldn't capture necessarily quality, but in terms of health gain or quality gain. And then using that as the measure of volume to back up prices, so that we're very cognizant of the fact that more volume doesn't necessarily mean more quality. And when we're thinking about what we get, we're measuring quality gain and what we're paying for it. We need to move towards more measurement of that internationally to be able to compare systems, and that's not easy. But I think something that we should do and work towards. On the policy tool side, I think also, when we think about payment models that governments are using, we've seen in recent years a real emphasis in trying to bring quality into the conversation by setting targets around quality or efficiency targets that are cognizant of quality, and thinking about how we can monitor, if not, well, one, monitor that, and two, pay for that. And so I think there are different tools on the measurement end and on the policy end that we can do to try to make quality part of the conversation and not ignore it, because the risk is if we do ignore it, then potentially it gets left behind, or we could even do harm to it, and that's not something anyone wants.
Thank you very, very much. Okay, Astrid, back to you. It's been a busy chat box. Are there any more questions?
It has indeed been a lively chat box, and your answers to the first round really prompted a lot of questions. We got two sort of broad perspective questions that I would like to ask you, and that is around prevention, like with these rising costs, and is there an invisible shift towards prevention? We often go back to prevention as sort of the answer to a lot of questions, but we somehow don't seem to get there. But do you see some changes in the government policies, like are governments pursuing prevention plans? Is it a worthy effort, sort of to say? And the second question is, if we were to have a new pandemic and a new high inflation period, what would happen? Would health systems collapse? Where do you sort of see this trend going with all these different shocks that we keep experiencing?
Okay, so time to get out our crystal balls, isn't it?
Yeah.
John, I'm going to hand that over to you.
No, I think these are good questions. Thinking about prevention, I think I have an unpopular perspective on this, which is that yeah, maybe prevention does save money in the long run, but ultimately, if we think about this issue of inflation from the perspective of this framework, the challenge with inflation is that you need to somehow maintain the incomes of the different stakeholders in the system, right? So even if you're able to reduce the incidence of disease, are you going to address that by cutting back on provider incomes? Are you going to, who's going to have less money in the system as a result of this? And when is that actually going to take place? Is it going to be that you prioritize prevention and so suddenly you're able to cut your health spending? I think that there's no good evidence that prevention is going to save money in the long term. It costs money to do these things. It's better, you want people to be healthy, but is it the solution to the challenge of prices increasing in the rest of the economy? I think probably not. A related question, would health systems collapse? I mean, I think this is a really difficult question, but I think it's a delicate balance. Obviously, if health systems were to automatically update their budgets and their prices to account for price growth, that would eventually become unsustainable because it would force health prices and volume prices, and quality would increase. And so spending would increase much faster. I think that it's a delicate balance where countries need to exercise or health systems or purchasers need to exercise their monopsonist position and keep control over prices, as they do with medicines and medical products, with health technology assessment. There's lots of levers that enable, which Irini talked about in the beginning, enable them to control the prices paid in healthcare. And so I think that it's important that they continue to exercise their control over prices, but that they have to give some way as well. Obviously, if they overdo it, for lack of a better word, then you will see pushback, and you see strikes, and you see people going more to private care, and you see more of a two-tiered type of system in otherwise universal setups. So that's my view on those two impossible to answer questions.
Thank you very much, John. Luca, did you want to add something?
Yeah, a slightly different view about prevention. I think I agree that it's all about revenue, providers' revenue, but what we need to think about is exiting the market if the provider cannot stay in business because of the change in service delivery toward more preventive care. So we need to think about regulation to exit the market or restructuring capacity, so the offer. So I think that could be a direction to think about, instead of saying prevention could be in the long run with a high rate of return of the investment. I think it is now a shift toward healthy aging that Irene mentioned, more prevention. And then if providers exit the market because it's not profitable enough, I'm fine if we regulate also this exit from the market. Thank you.
Thank you very much. Irene, over to you.
Yeah, I've been dying to come in on this. I also think I share John's unpopular view that sometimes that prevention is seen as maybe this panacea to rising costs. I think if we think about what prevention is, primary prevention, maybe like social policies, secondary prevention, diagnosis, screening, tertiary prevention, managing care. There's several of those things that may prevent illness, but a lot of prevention is managing illness and finding illness. And so if I'm diagnosing more people and giving them treatment, that doesn't always reduce spending. In fact, good prevention can increase spending. If I diagnose everybody who has multimorbidity and treat everybody who has multimorbidity, that's a great thing for health outcomes, but it may not be a great thing for health spending. And I think sometimes it's wrong that we think of the outcome of prevention, the desirable outcome, as health spending, because it's exactly this quality component in the middle. What's the end game here? The end game is finding people, is yes, preventing illness, but a lot of prevention is also finding illness and treating illness. And just to highlight things that are making this more complicated, think of the GLPs and the role they're playing in prevention, but also the role that they're playing in health expenditures and innovation. There's a lot of new innovative tests and treatments that are part of prevention, but are going to push health expenditures up. So I think, it's a more complicated argument. And prevention is definitely good, but the effect that it has on health expenditures is not necessarily always just that it's going to bring them down. On this other very difficult question of a new pandemic and a new inflationary period, I'm also going to go out of the box here a little with my answer and say, I think we really need to rethink how we think of health systems in this new period of new global shocks, climate shocks, pandemics. These are shocks that affect everybody. These are shocks that no one country can prevent entirely. It requires working together, both to mitigate the frequency of these shocks, but also to respond more effectively. These shocks, while are global, don't hit everywhere at the same time. And if we can find a way to work better together across boundaries, share resources, think more collectively, I think this is what's going to make systems resilient and sustainable. But it requires a very different thinking of health systems and how we work. And I think the sooner we start doing that, the better for all health systems.
Thank you very much. Thank you. So we only have a couple of minutes left. I'm going to hand back to Astrid to see if there's any nice, big, chunky, juicy questions. Just one that we can zip through very quickly. For all
There's some
speakers.
Really good questions in the chat, but I wanted to. They're very specific, so unfortunately don't think we have time for those. But maybe a big juicy one is, and we've already touched a little bit upon it with this impossible question we had before. But where do we go? Like, what's next? Where do we go from here? What is, in your opinion, like the next steps? Okay,
so future steps. Who should we start with? Should we start with Irene on this? because you got so fired up on the last round of questions. I came to you last.
This is the one when I was like, oh, good, I'm glad I'm last. I think next steps are, I mean, I think we need to get better at the metrics that we're using to compare so we can learn what works from one system to the other. You know, I mean, this is where my own work and my motivation is that all of these systems are doing things differently. There's so much opportunity to learn, and yet we don't have the tools that allow us to really compare to be able to learn. So I think a big thing that we need to do is to get better at creating measures, harmonizing the way we measure prices and volumes and across countries, and so that we can learn really what are the policy tools that work and implement those in countries that aren't already doing them. So that would be my one thing.
Thank you very much. If we're going to talk about metrics and we're going to talk about measurements, I have to hand over to Luca. You know, this is your field, your OECD. What are you going to do about it?
My preferred option would be to drill down at functional level. So what we discussed today at health system level, I would love to tell you more at our next webinar about trends in price and volume in pharmaceutical spending, in hospital spending, outpatient care. So that would be my first best choice. Thank you, Erica.
Thank you very much. Thank you. And John, so why don't you talk us out?
No,
if we take away nothing else from this webinar, what should it be and where should we be going? What's our level?
No, of course. No, first off, thank you everyone for joining. I think that the takeaway here is that we need to pay attention to what's driving health spending, and we need to understand the mechanisms. Obviously, countries cannot continue to spend more and more and more in excess of their GDP year on year. And so really understanding how these external factors like inflation in the broader economy affect the health system, but also understanding what the mechanisms are that enable the health system to be sustainable, to be resilient in light of these types of pressures is really important. And you know, I was thinking it was nice that I was the last one in this list of where to go forward. I mean, I think that it's important for health systems to really find. You know, I was talking about that how countries can't sustainably automatically update their budgets for the sake for inflation, but they need to find the sweet spot of how much they and the mechanisms that enable them to reach that sweet spot of how much they can adjust how much they spend or how much the prices are that they pay in light of the broader economy without disrupting the balance of people being able to access healthcare, providers being able to have relatively stable guaranteed revenues. So I think that this is really the challenge, and obviously the measurement plays a big part in that, as well as really understanding the differences in policy mechanisms across countries. So it's 2 o'clock exactly on my clock. So
we've got yes, we're getting up to time now. So thank you very much for joining us. This is the first in our autumn series of webinars. We've got a big chunk of series of webinars coming up linked to the SDGs. Please do join the mailing list. That way you'll be the first to find out about it. But thank you, everyone. It's been wonderful to talk to you today, and I look forward to seeing you all soon. Take care now. Bye-bye.